All right, welcome everyone. So we're going to look at something called the Renin Angiotensin Aldosterone system, right? So what this system is, essentially think of this as a system that is acting to increase blood pressure in instances of decreased blood pressure. So you have a decreased blood pressure because of massive dehydration due to bleeding and hemorrhage, something like that. This system, renin angiotensin aldosterone system, the RAAS system as it's sometimes called, is going to act to increase this blood pressure, right? So there's a few main kind of molecules that we're going to discuss, main kind of proteins and molecules. And so the first one is something called angiotensinogen, right? This is formed in the liver. It's naturally circulating in the body. And this ending, when you see something with the ending ogen, that means inactive, right? This is the inactive form. And so this angiotensinogen, inactive, it's always circulating, it's converted into its active form, angiotensin 1, by something called renin. And renin is released from the region of a kidney called the juxtaglomerular apparatus. The JGA, juxtaglomerular apparatus, releases renin, and it converts angiotensinogen to angiotensin 1 by cleaving off a certain number of amino acids, right? This angiotensin 1 is then converted to angiotensin 2 by something called angiotensin converting enzyme, or ACE, ACE, it comes from the lungs. It can also come from the kidneys as well. But this angiotensin converting enzyme is going to activate angiotensin 1 to 2, and then angiotensin 2 is going to do a number of very important things, right? Essentially, all of them, and we'll look at a graphic here in the next slide. All of the effects of angiotensin 2 are going to be to increase blood pressure in some way, shape, or form. It does it in different ways, but the end result of angiotensin 2 activity is to increase blood pressure, right? So it does it through a number of mechanisms. One is stimulating thirst, right? So it stimulates thirst centers in our hypothalamus, promotes the intake of water. Angiotensin itself, if you look at the name, angio means blood vessel, or refers to blood vessel, and then tensin, think tense, so constrict, tighten, right? So angiotensin 2 constricts blood vessels. So it itself is a very powerful vasoconstrictor, right? Thus raising resistance, increasing blood pressure, right? It's also acting on our kidney in a number of different ways, specifically through aldosterone's action and antidiuretic hormones action, right? So if we look at these, we can see pretty much all of these main effects, right? So here we see angiotensinogen, right, being converted into angiotensin 1 via renin. Renin is from that juxtaglomerular apparatus. Angiotensin 1 to angiotensin 2 via ACE, right? We'll come here and talk about ACE inhibitors here in just a second. And then angiotensin 2, you can see all of the downstream effects of angiotensin 2, right? So notably, all of these things, so sympathetic drive, reabsorption of sodium and water through aldosterone, vasoconstriction, ADH release, all of those are acting to raise blood pressure, right? They're all acting to increase blood pressure through different ways, right? Through different actions. And so you can see here, as we reabsorb sodium, right, so too we are reabsorbing water, right? So this is something called obligatory water reabsorption. Water is obliged to follow sodium, right? And that's through aldosterone's action, right? So again, aldosterone is from the adrenal cortex, right? What region of the adrenal cortex? Do you remember? It's from the zona glomerulosa, right? So increased sodium, increased water, so increasing blood volume, increasing blood pressure. Vasoconstriction at the level of the arterioles, right? And so a lot of the vasoconstriction is happening at the smaller blood vessel level, right? So think arterial as opposed to big, elastic arteries like the aorta and things like that. And that's because smaller arterioles, smaller blood vessels, actually have a higher or a greater cross-sectional area when you consider their total number, right? And so if you constrict the arterioles, you're actually going to have a bigger effect on blood pressure than if you say constricted, actually larger arteries, right? And then you have your antidiuretic hormone, right? So to diurese, right? Diurese means to excrete urine, right? So to release urine. So something that is an anti-diuretic serves to decrease that, right, or oppose that. So in other words, retain more water, right, reabsorb more water, thus increasing blood volume, thus increasing blood pressure, right? So you can see here, if you form angiotensin II, you get all of these downstream effects, right? So say you have hypertension, right, and you take an ACE inhibitor, right? So ACE inhibitors, they all end in pril. That's kind of an easy way to tell that a medication is is an ACE inhibitor, ends in PRIL. So there's benazepril, captopril, lisinopril, quinapril, ramipril. There's all of these different medications that end in PRIL, and they're all ACE inhibitors, right? So if you inhibit the action of ACE, right, so you block ACE receptors, then you're blocking the formation of angiotensin II. So you block all of these downstream effects, right? If all of these downstream effects act to increase blood pressure, then blocking angiotensin II formation through an ACE inhibitor is going to act to decrease blood pressure, right? So again, patients with hypertension. Now, patients who take ACE inhibitors, oftentimes they may experience a cough, and a cough is kind of one of the main side effects of an ACE inhibitor. In that case, they may be moved to a medication called an ARB, or an angiotensin receptor blocker. So in other words, it's going to cause a result in basically the same thing, but instead of acting through ACE, those ARBs, or angiotensin receptor blockers, are going to act through blocking angiotensin II directly, and not the formation of angiotensin II. Right. So you can look at a graph like this. You can look at one kind of like this, a little less scary of a graph, but you see those same basic things. So angiotensinogen inactive, renin converts it to angiotensin 1. Angiotensin 1 is converted to angiotensin 2 via ACE, and then angiotensin 2 does all of those things we talked about. So vasoconstriction, decrease urine formation through aldosterone and ADH, stimulate the thirst center in the hypothalamus, all of that acting to increase blood pressure, right? So if we take a look at some of these specific mediators of this process, so aldosterone, again, adrenal cortex, think zona glomerulosa, right? Several different stimuli. Main one is angiotensin II for its release. And big thing with this is what it's doing. It's acting to reabsorb sodium and water, right? So this should really say increases reabsorption of sodium and water. As sodium is reabsorbed, water is going to follow it. Again, that's that obligatory water reabsorption and decreased urine output. You have something similar with ADH, but ADH, instead of acting through sodium reabsorption and then water following it, it's acting just on water reabsorption, right? And so remember, this is made in our hypothalamus. It's stored in the posterior pituitary, right? You have the stimuli for ADH release is a high plasma osmolarity, right? So if you look at this graph over to the right, this essentially means the blood is more concentrated, right? There's more things in the blood, right? So stimulated by increased blood concentration or the angiotensin II that we talked about previously, right? So you release ADH. ADH is going to increase water intake through our thirst mechanism and decrease water excretion. So through the kidney, right? And so with this, we're then going to bring in more fluid into the blood, increase blood volume, increased blood pressure, right? Now, ADH in a more clinical context, you may see it called vasopressin, right? So this term down here, vasopressin. Vaso meaning vessel, and pressin meaning to press or constrict, right? So again, vasopressin ADH in a clinical setting is given to help individuals with low blood pressure, right? So again, helping increase resistance, increase blood pressure, right? And then you have one called ANP, right, or atrial natriuretic peptide. Now, this is acting largely in the opposite direction, right? So instead of acting to increase blood pressure, this is acting to decrease blood pressure, right? So atrial natriuretic peptide is a hormone, a molecule that acts to decrease blood pressure in response to an increased stretch of our heart's atrium, right? So if you have increased stretching of the heart, right, what do you think that indicates, right? If the heart is stretching more than it normally does, that probably indicates that there's increased blood volume, right, in the circulatory system. So it's stretching the heart a little bit more. So in response to this increased stretch, the heart's atrium, the wall there, the lining, releases this atrial natriuretic peptide. And the atrial natriuretic peptide acts to promote vasodilation, and then also decreased renin, decreased angiotensin II, decreased aldosterone, decreased blood volume, decreased blood pressure. Right. So again, basically the exact opposite effects of what you have with things like aldosterone and things like antidiuretic hormone. Right. So this is acting to go in the opposite direction. Okay. So here you can see a nice kind of graphic showing what would happen in the event of increased atrial. So again, increased volume, increased atrial stretch, increased atrial natriuretic peptide release. This right here, this is referring to what's happening to our afferent and efferent arterioles. This is two blood vessels in the kidney leading into something called the glomerulus. So you get vasodilation of the afferent arteriole that goes into the glomerulus. You get vasoconstriction of the efferent arteriole. This is acting to increase something called GFR, or glomerular filtration rate, which is essentially the amount of fluid that we're filtering in the kidney per minute, which is related to and associated with the amount of urine that we're producing. So if we filter more, we make more urine, which means less fluid in the blood, which is going to act to decrease blood volume, right? And that's what we were trying to correct here, right? So we had a high blood volume, and we're trying to decrease it through increasing the amount of urine that is produced, right? So consider all of these things. Again, renin, angiotensin, aldosterone system, the major players there, right? So renin, angiotensin, aldosterone, antidiuretic hormone, and then you can also consider ANP that we just discussed, right? So again, renin, angiotensin, aldosterone system. So what you should do, or one of my suggestions when you're studying this, is think about when you get to a certain point, right? If you're looking at a graph, right, or you're looking at some drawing that you've made, when you get to a certain point, try to then explain all of the downstream effects that are going to occur, and then consider what would happen, say, if you blocked one of these, right? So like we mentioned, if we block the formation of angiotensin II, what are the downstream effects? If we make angiotensin II, but then we block it from binding to its receptor, what's going to happen, right? If we block the reabsorption of sodium or water, what's going to happen? If we have too much reabsorption of sodium and water, what's going to happen, right? So again, think of the more downstream effects of some of these processes, okay? So reach out if you have any questions, and I will be happy to answer.